Thank you, Vasak. Indeed, it's a pleasure to be with him for his courses. For last so many years, we have been talking on keratoplasty, endothelial keratoplasty in various forums. And thankfully, people have grown up to doing a lot of keratoplasty now. We have not many people doing endothelial keratoplasty surgery. As you rightly showed, every year we are producing around 13 to 15,000 endothelial decompensation only because of cataract surgery. That's a large number, and he said around 5,000 surgery per year. That means we have to double the number of surgeries in the next few years, and number of surgeons has to also increase in that regard also. And looking into the way we prepare the donor is very, very important. And in India, the DSEC is going to remain for quite a long time. We do have a lot of challenging cases where we may have to do DSEC rather than DMEC in those cases. I understand the expert surgeons may be able to do DMEC in all type of endothelial decompensations. But we do have people graduating into endothelial keratoplasty. They have to do DSEC first, then slowly turn over to DMEC type of surgeries. So you can do manual surgeries or automated donor preparation. In automated, we do have microkeratome assisted surgeries, or you can have a femtosecond laser assisted preparation of graft also. Microkeratome assisted surgeries are far better. You can do a single pass. You can aim the required thickness of a tissue also. You can do a double pass surgery so that you can do a thinner graft also in these cases. There are various equipments which are available in India also. You have a Moria system, you have a Gyogor, you have Amados, then you have Nitro. Nitro is an Indian company which makes this microkeratomes easy and cheaper available with a similar predictability of cuts. Therefore, it's not really looking into a cost-wise to look into an investment, especially for institution. I think it do require keratomes, not only for a DSEC preparation, for various other lamellar procedure also. The little difference in preparation of artificial chamber or pressurization of donor lenticule in these cases, for a artificial chamber which we use for keratomes, you require a tight entry chamber in these patients, adequate donor rim so that it doesn't slip out when the keratome is moving over the donor tissue, and maintain the pressure throughout your movement of a keratome, which is very, very important in these cases. Always maintain the high pressure by keeping a bottle height a little more, and you can clamp the IB attachment at around 15 centimeters so that the fluid doesn't go backwards when the keratome is moving over the cornea. Always make sure if you're using this type of keratome where the rotation is manual, around 15 to 20 seconds is classically described to get a good cut in these cases. But now we have cases where you can do no rotation is required by physically, it is automated. The first important thing in such cases of cutting with the microkeratome is to achieve a good thickness measurement for your cases. Whenever you're doing a microkeratome cut, the thickness of donor lenticule has to be assessed. That may be true for a manual dissection also. If you see here, this is the cornea which is there with us, and we can measure this corneal distance in an anti-segment OCT and gives you an accurate measurement also. You have to do an ultrasonic pachymetry on the table to see what is the thickness of your donor tissue. Subsequently, you plan your surgery accordingly. Here, this thickness may be around 520 or so. I have taken 400 micron blade here, and that will give us around 100 micron plus minus 10 or 20 microns. So anything around 100 microns is desirable for DSEC surgery nowadays. You can see after a cut, we go backwards and see what type of cut we have achieved. You can see a uniform cut which is achieved here is around 120 microns tissue, which is uniform. Subsequently, we'll put a mark in the peripheral areas so that you can, when you trephine from endothelial side, you achieve a nice definition, central definition. That is true for a manual dissection also. When you take it to the Teflon block, it's difficult to see what is periphery actually located in these cases. So this peripheral marks will help us. You can see here now, these peripheral marks will be really important to visualize which is the peripheral area. The central definition will help you achieve a good central cut in these cases. Normally with keratome, we achieve around 10 millimeter cut, and requirement for DSEC tissue is around 7.5 to 8 millimeter. Therefore, the cut which is little thicker in periphery is avoided so that you get a uniform thickness in these patients. So this is with 350 micron head. You can see around 200 micron thickness all around. But with a new keratome system, when you make a ultra-thin DSEK lenticule, you can see here, it is around 69 microns and 84 micron periphery. So this is what thin lenticule you need to achieve in these cases. And this is the day 1 or day 2 of surgery, where you have a little bit of edema coming up. But same graft after 6 months will look like just a 50 micron graft, and is as good as normal surgery in your patients. This is our results. This is published in 2014. You can see here, at 6 months, we achieve around 50 to 80 micron tissue, so which gives a very nice anatomical and physiological graft in these patients, and visual acuity almost 6.9 in 80% of the cases, around 20% cell loss at 6 months. So this is what you achieve in most patients. Look here, this is around 67, 61 microns. This type of thin grafts are required for your patient by DSEK, which I think can be achieved both manually as well as the cases with the automated keratome also. Then you can have another system, it's a Gabor system, which is, it doesn't require a cylinder to be attached. It's an electrically run motor. So you have to just attach to your power point, and the system can run hand-free totally. You don't have to, the stand is there which puts the keratome into the place, and everything runs automatically and gives a very nice cut in these cases. Just to show you one classical cut, again here you can see the corneal thickness has to be measured for these patients, then accordingly you choose the keratome head. You can have a keratome head right from the 100 micron to a 600 micron in these cases. Accordingly you can choose these patients also. And this movement is pre-fixed. You don't have to move your hand faster or slower. It will go by own speed. Therefore, you get a very nice cut in these patients. You can see here, this will be around 100 micron thickness tissue which has been achieved in this case. So both can be judged very, very nicely in these patients. And sometimes if you achieve a thicker graft, like in this patient, I got around 250 microns. You can always take a patient for a reorientation by another cut, which is called double pass technique. You can see here that tissue is around 250 micron here, which is not desirable in today's scenario. As I said, ultra-thin DSEK, which gives you good anatomical results and physiological outcomes, you require to do a thinner graft. So I've taken a 100 micron blade from other side, opposite from the previous side, which will give you around 60 micron thickness of tissue subsequently. So you can see both can be done. At this stage, you have to make sure your pressure is not very high, and you need to use a clear blade for a new blade for these cases. So this is around 80 micron tissue which can be used subsequently for ultra-thin DSEKs also. Recently, we have tried in a femtosecond laser application also, around 8 millimeter of the femtosecond. If you have these devices in your institution, you should plan with this. So first, we make a 8 millimeter cut at a depth of around 450 microns, depending on the thickness of tissue, again in these cases. So this you can see a deeper cut which is happening with this FS200, which gives a very nice deeper cut also. And once you see that the side cut has occurred at 8.5 millimeter, so we can take the patient to the side microscope and take out the entire tissue. Will give you a reasonably good thickness in these patients also. You can see I'm taking out the fluid from this thing. Subsequently, like you do for LASIK, you can just take the peripheral edge, lift the entire tissue up subsequently, and this is what you get, very thin tissue in these cases. You can see here. If you get a thicker tissue, irregular surface, we have used hexagonal laser PTK mode to smoothen the surface also in these cases. But the studies we have done with looking at electron microscopy and atomic force microscopy to see the surface and endothelial viability, you can see femtosecond does make a lot of damage to endothelial cells. Similarly, for a surface examination also, this is a femtosecond surface in atomic force microscopy study, and this is a microkeratome surface. It seems that microkeratome gives a better surface for a deeper cuts till date with a newer generation femtosecond laser also. So if you summarize the entire preparation, I think predictability is more important here, which is can be given by the microkeratome. Uniform smooth cut, leaving the peripheral thick tissue because it gives a 10 millimeter cut. As Basak rightly said, we can have a pre-cut tissue supplied to the various places, to surgeons, and achieve ultra-thin grafts, which is less than 100 micron. And the chances of damage to tissue with a keratome is very, very less. You don't require a second tissue with you most of the time, and does give you a value for the cost because you have a more predictability, better outcome for these patients, and you can train your iBank technicians to do this cut for your patients, which can be supplied to our various organizations with a lot of requirement in there for a country where people need to do endothelial keratoplasty for such a large number of patients. Thank you for kind listening.